Welcome to Part 2 of GI Tract Review. Pancreatitis often presents with epigastric pain radiating to the back, which typically improves when the patient leans forward. In small bowel obstruction, presentation with cramping, abdominal distension, vomiting, absence of flatus, and periumbilical pain, especially with a history of prior abdominal surgery, even appendectomy. Third, acute mesenteric ischemia presents with pain out of proportion to the exam, located periumbilically, can also have metabolic acidosis and risk factors like atherosclerosis or atrial fibrillation. Best imaging modality for pancreatitis are lipase and CT scan. For SBO, we need to do X-ray/CT scan of abdomen, which shows dilated bowel loops with air fluid level. In small bowel acute mesenteric ischemia, we do CT angiography. If concerned for gallstone pancreatitis, do ERCP and cholecystectomy to be performed after ERCP. Pancreatic pseudocysts are fluid collections that can develop after an episode of acute pancreatitis, typically once the inflammation has resolved. Patients may present with persistent elevation in lipase, abdominal fullness, or early satiety due to the mass effect of the pseudocyst. To diagnose a pancreatic pseudocyst, the initial imaging modality is a CT scan of the abdomen, which typically reveals a thick-walled, fluid-filled mass adjacent to the pancreas. To further characterize the lesion and differentiate it from a cystic neoplasm, an endoscopic ultrasound with fine needle aspiration, FNA, may be performed. Management depends on the patient's symptoms. If the pseudocyst is asymptomatic, it often resolves on its own, and no intervention is necessary. However, if the cyst is symptomatic or complicated, such as in cases of infection or biliary or duodenal obstruction, then drainage is required. This can be done endoscopically, which is the preferred method, or via surgical or percutaneous approaches depending on the clinical scenario. Ischemic colitis typically presents with acute onset abdominal pain, often localized to the left side, accompanied by hematochezia. It is caused by transient hypoperfusion, especially in the watershed areas of the colon where blood supply is most vulnerable. You should suspect this condition in elderly patients, particularly those with sudden onset of hematochezia in the setting of a low-flow state, such as hypotension, volume depletion, or during dialysis. For diagnosis, the initial imaging modality is a CT abdomen with contrast, even in patients on hemodialysis, to evaluate for bowel wall thickening and distribution of the disease. However, definitive diagnosis is confirmed with colonoscopy, which can directly visualize the ischemic changes. An important distinction to remember: unlike acute mesenteric ischemia, which presents with severe pain out of proportion and requires angiography, colonic ischemia typically causes bloody diarrhea and pain localized to the left colon. In these cases, CT with contrast is the preferred imaging modality, not angiography. Ogilvie syndrome is an acute, functional obstruction of the colon that occurs without any mechanical blockage. It typically affects the cecum and right colon and arises due to an imbalance in the autonomic nervous system, where there is increased sympathetic tone or reduced parasympathetic activity. To diagnose Ogilvie syndrome, the first step is an abdominal X-ray, which often reveals a massively dilated colon, especially the cecum. A CT scan or contrast enema is then performed to rule out a true mechanical obstruction. Initial management is supportive. Patients are kept NPO, and electrolyte imbalances are corrected. If there's no improvement in 2 to 3 days, the next step is to consider pharmacologic treatment with intravenous neostigmine, a cholinergic agent that stimulates colonic motility. Patients should be closely monitored with serial abdominal exams and repeat X-rays to assess for risk of perforation, especially if colonic dilation persists or worsens. Microscopic colitis is a form of chronic diarrhea that presents with watery, non-bloody diarrhea, often accompanied by urgency. It is called microscopic because the colonoscopy typically appears normal, and the diagnosis is made only through histologic examination of colonic biopsies. On biopsy, 2 subtypes can be identified: lymphocytic colitis, which shows increased intraepithelial lymphocytes, and collagenous colitis, which shows a thickened subepithelial collagen band. Management begins with the discontinuation of any offending medications such as proton pump inhibitors, PPIs, NSAIDs, or SSRIs, as these are commonly associated with triggering the condition. Smoking cessation is also advised. As smoking has been linked to increased risk, the first-line treatment for symptomatic patients is oral budesonide, a corticosteroid with low systemic absorption that helps reduce inflammation in the colon. Celiac disease is an autoimmune condition triggered by gluten, leading to damage of the small intestinal mucosa. Diagnosis begins with serologic testing, specifically looking for anti-tissue transglutaminase IgA antibodies or anti-endomysial IgA antibodies. If these serologies are negative, it's important to measure total IgA levels, since IgA deficiency is common in celiac disease and may lead to false negative results. If the serology is positive, or even if negative but there is a strong clinical suspicion, an upper endoscopy with small bowel biopsy should be performed to confirm the diagnosis. In patients with the classic skin manifestation, dermatitis herpetiformis, a skin biopsy can also be diagnostic. Treatment of the skin condition often requires dapsone in addition to a strict gluten-free diet. Celiac disease is also associated with metabolic bone disease, particularly osteoporosis. This can present with signs of vitamin D deficiency, such as elevated parathyroid hormone, low phosphate, and high alkaline phosphatase, even with normal calcium. Because of this risk, a DEXA scan is recommended at the time of diagnosis and repeated in 1 year if osteopenia is found. Importantly, celiac disease can cause hyposplenism, increasing the risk of infections with encapsulated organisms. Therefore, pneumococcal vaccination is recommended for all patients with celiac disease, although the exact cause of the hyposplenism remains unclear. Enteropathy-associated T-cell lymphoma, or EATL, is a rare but serious complication that occurs in patients with celiac disease, particularly those with poor dietary compliance and ongoing gluten exposure. This malignancy arises from the T cells in the small intestine and represents one of the most feared consequences of uncontrolled celiac disease. Clinically, patients with EATL may present with abdominal pain, systemic B symptoms such as fever, night sweats, and weight loss, along with hepatosplenomegaly, ascites, and in severe cases, bowel obstruction, perforation, or gastrointestinal bleeding. The diagnosis of EATL is confirmed by histopathological examination of a resected tumor specimen. Unfortunately, the prognosis is poor, and management typically involves combination chemotherapy. Early recognition is critical, but outcomes remain challenging despite treatment. Celiac disease is best diagnosed with tissue transglutaminase antibodies, TTG-IgA, and duodenal biopsy. These tests are highly accurate in most patients, but it's important to note that the diagnostic findings, especially serologic markers and histologic abnormalities, can begin to normalize within a few months after starting a gluten-free diet. This is why testing must be performed before dietary gluten is removed. In certain cases where the diagnosis is uncertain, genetic testing for HLA-DQ2 and HLA-DQ8 may be helpful. Although these markers have low specificity, they are positive in more than 99% of individuals with celiac disease. Importantly, HLA typing is not affected by a gluten-free diet, making it a useful tool when serology or biopsy results are inconclusive due to prior gluten restriction. Crohn's is most commonly seen in the terminal ileum and colon. During colonoscopy, typical findings include aphthous ulcers, cobblestoning of the mucosa, and skipping lesions. Atypical anal fissures may also be a presenting feature of Crohn's. These fissures tend to be multiple, painless, deep, and often non-healing. If a patient has fissures that do not improve despite 8 weeks of optimal treatment, a colonoscopy should be performed to evaluate for underlying Crohn's disease. Another serious complication is the development of rectovaginal fistulas, which can present with vaginal fecal discharge, increased vaginal gas, or a foul-smelling discharge. These symptoms should raise concern for a fistulous connection between the bowel and the vagina. Initial treatment depends on the severity of the disease. For mild symptoms, antibiotics may be sufficient. For moderate to severe cases, anti-TNF agents are commonly used. Surgery is typically reserved for patients who do not respond to medical therapy or those who develop complicated or recurrent fistulas. Ulcerative colitis is a chronic inflammatory bowel disease that always involves the rectum and progresses in a continuous fashion proximally through the colon. On colonoscopy with biopsy, typical findings include continuous mucosal inflammation, crypt abscesses, and the presence of pseudopolyps due to repeated cycles of healing and ulceration. While not diagnostic, the PANCA antibody is positive in about 60 to 70% of patients and can provide supportive evidence for the diagnosis. Ulcerative colitis also has several important extraintestinal manifestations, which may affect other organ systems. These include arthritis, typically non-deforming, and ankylosing spondylitis skin manifestations such as erythema nodosum and pyoderma gangrenosum primary sclerosing cholangitis, which has a strong association with ulcerative colitis. Ocular involvement, such as uveitis and episcleritis. Recognition of both intestinal and extraintestinal features is essential for comprehensive care and management of patients with ulcerative colitis. The management of ulcerative colitis depends on the severity of disease and the treatment phase. Corticosteroids are commonly used to induce remission during acute flares. However, they are not appropriate for long-term maintenance because of their side effect profile. For mild to moderate disease, maintenance therapy involves 5-aminosalicylic acid, 5-ASA, agents such as mesalamine. These can be administered as topical formulations like suppositories or enemas, or taken orally for more extensive colonic involvement. When the disease is moderate to severe, or when patients do not respond to 5-ASA, immunosuppressive agents such as azathioprine, 6-mercaptopurin, or cyclosporine are considered. In addition, anti-TNF agents may be used for more aggressive or refractory cases. Finally, if the disease remains refractory to medical therapy, or if complications arise, a colectomy may be necessary, which is curative for ulcerative colitis. A severe ulcerative colitis flare typically presents with 6 or more bloody bowel movements per day, accompanied by abdominal cramping, weight loss, fever, and tachycardia, all signs of systemic inflammation and significant disease activity. Laboratory findings often include an elevated erythrocyte sedimentation rate, ESR, leukocytosis, and anemia, reflecting active inflammation and chronic blood loss. Initial treatment involves high-dose glucocorticoids combined with high-potency 5-aminosalicylic acid, 5-ASA, compounds. If there is no clinical response within 7 to 10 days, escalation to cyclosporin or a tumor necrosis factor, TNF, inhibitor is indicated. For patients who are refractory to medical therapy, a colectomy may be necessary. This surgical intervention is curative for ulcerative colitis and is often the last resort for those with persistent or life-threatening disease. Small intestinal bacterial overgrowth, or SIBO, occurs when there is an abnormal increase in the number or type of bacteria in the small intestine. This condition is often seen in patients with anatomical changes following GI surgeries, or in those with impaired gut motility due to disorders like systemic sclerosis or gastroparesis. It may also develop in individuals with chronic pancreatitis, where a lack of digestive enzymes allows bacteria to proliferate. Patients typically present with bloating, excessive gas, and chronic watery diarrhea, often related to malabsorption. There may also be nutritional deficiencies, especially a decrease in vitamin B12 due to bacterial consumption, and increased folate levels as a result of bacterial synthesis. The diagnosis of SIBO can be made using a carbohydrate breath test, either with lactulose or glucose, which detects hydrogen or methane produced by bacterial fermentation. Alternatively, a definitive diagnosis can be established by endoscopy with jejunal aspirate and culture, though this is less commonly done. Treatment involves oral antibiotics such as rifaximin, ciprofloxacin, or doxycycline, which target the excess bacterial load and improve symptoms. Sigmoid volvulus is a form of true mechanical obstruction caused by the twisting of the sigmoid colon, leading to blockage of the intestinal lumen. It is most commonly seen in elderly individuals, especially those in nursing homes, and is often associated with chronic constipation, neuropsychiatric conditions, and a sedentary lifestyle. On imaging, An abdominal X-ray may reveal the classic coffee bean sign, which represents a dilated, inverted U-shaped loop of the sigmoid colon, a hallmark feature of this condition. On CT scan, a bird beak appearance is seen at the point of torsion, where the bowel loops converge. The first-line treatment is sigmoidoscopic detorsion, a procedure that untwists the colon and relieves the obstruction. If detorsion fails or if there are signs of bowel ischemia or perforation, surgical intervention may be required. In the absence of alarm features, chronic slow transit constipation can be treated with dietary fiber and lifestyle changes. If pharmacologic therapy is indicated, an initial trial of bulk-forming laxatives such as methylcellulose or psyllium is preferred. Vomit-predominant diarrhea is present in Staph aureus, Bacillus cereus, and novovirus. Staphylococcus aureus presents with acute vomiting, minimal diarrhea, and is classically linked to buffet food left out for long periods. Bacillus cereus, also vomit-predominant, especially when associated with reheated rice. Norovirus, a highly contagious virus, common in outbreak settings like cruise ships, with sudden onset vomiting and diarrhea. Watery diarrhea predominant present in Clostridium perfringens and enterotoxic E. coli. First being Clostridium perfringens, often from improperly stored food, such as dishes left unrefrigerated. Second is enterotoxigenic E. coli, ETEC, common cause of traveler's diarrhea. Next type of diarrhea is inflammatory diarrhea. These organisms invade the intestinal mucosa or produce toxins, resulting in bloody diarrhea, fever, and abdominal pain. 1. Salmonella, acquired from eggs or poultry. 2. Shiga toxin-producing E. coli, STEC, especially from undercooked beef, can lead to Hus. 3. Shigella. 4. Vibrio, associated with raw shellfish, especially in those with liver disease or immunocompromise. Next, Yersinia and Campylobacter, also known to cause inflammatory diarrhea. Acute voluminous, non-bloody, and foul-smelling diarrhea indicates steatorrhea, which is common in Giardia. Do stool microscopy testing in such cases. In traveler's diarrhea, which med to take with you? Answer is FAR. Fluoroquinolones, azithromycin, rifaximin. When factitious diarrhea is suspected, often in patients with unexplained chronic diarrhea or inconsistent symptoms, a 24-hour stool collection is performed to assess stool osmolality and investigate the possibility of manipulation. Start by measuring stool osmolality. If the osmolality is less than 250, it suggests that water has been added to the stool, an indicator of factitious behavior. If the osmolality is greater than 450, it's important to check urine sodium and creatinine to rule out urine contamination of the stool sample. If the osmolality falls between 250 and 400, calculate the osmotic gap using the formula. Measured osmolality, 2 Peutz-Jeghers, Na plus K. If the osmotic gap is less than 50, this points toward a secretory diarrhea, which could be caused by stimulant laxatives such as senna or bisacodyl. If the osmotic gap is greater than 75, it suggests osmotic diarrhea, possibly due to ingestion of substances like lactulose, sorbitol, magnesium sulfate, e.g., Magol, mineral oil, or PEG. In such cases, it is also appropriate to measure fecal fat to evaluate for malabsorption. Additionally, colonoscopy may show melanosis coli, a dark pigmentation of the colon often seen in chronic laxative abusers, further supporting a diagnosis of factitious diarrhea. Secondary lactose intolerance presents with increased borborygmy, bowel sounds, and decreased pH causing cholesterol gallstones. Treatment involves bile salts like cholestyramine and fat-soluble vitamins. The management of Clostridioides difficile infection, or CDI, depends on the severity of disease. For non-severe CDI, patients typically present with profuse watery diarrhea and abdominal pain without systemic complications. These cases are treated with oral therapy, either fetixomycin or oral vancomycin, both of which are effective in resolving the infection and reducing recurrence. If the patient meets criteria for severe CDI, which includes symptoms plus either a white blood cell count greater than 15,000 or a serum creatinine above 1.5 mg/dL. The same oral therapies, phytoxamicin or vancomycin, are still used, but with closer monitoring due to the risk of progression. In fulminant CDI, patients present with signs of systemic toxicity, such as hypotension, shock, ileus, or toxic megacolon. These cases require oral vancomycin combined with intravenous metronidazole. This dual approach ensures both local and systemic coverage due to impaired gut motility or absorption. For patients who do not improve with standard treatment, we classify the infection as refractory CDI. In such cases, treatment may escalate to fecal microbiota transplantation, FMT, or even surgical intervention, especially if there are signs of perforation or worsening sepsis. Perforation after colonoscopy is rare but possible, especially if polypectomy done first step is to do upright chest X-ray and abdomen X-ray to look for free air. If high suspicion with negative X-ray, we perform CT scan with water-soluble contrast as it can detect subtle perforation. Certain gastrointestinal malignancies are associated with specific predisposing conditions that significantly increase the relative risk of cancer development. Starting with esophageal cancer, risk factors include achalasia, where esophageal motility is impaired, and gastroesophageal reflux disease, GERD, which can lead to Barrett's esophagus, and subsequently, adenocarcinoma. Additionally, atrophic gastritis and a history of gastrectomy are also linked with increased esophageal cancer risk due to changes in the gastric and esophageal environment. Moving to gastric cancer, several factors contribute. These include atrophic gastritis, gastric ulcers, and chronic Helicobacter pylori infection, all of which promote chronic inflammation and mucosal damage. A history of gastric surgery, such as partial gastrectomy, and conditions like pernicious anemia, which leads to intrinsic factor deficiency and atrophic gastritis, further elevate the risk. Finally, colon cancer risk is markedly increased in patients with chronic inflammatory bowel diseases, namely ulcerative colitis and Crohn's disease, due to chronic mucosal inflammation and dysplasia over time. Peutz-Jeghers syndrome is a rare, autosomal dominant genetic disorder characterized by the presence of hamartomatous polyps throughout the gastrointestinal tract, as well as pigmented mucocutaneous lesions, typically on the lips, buccal mucosa, and digits. These patients are at an increased risk for malignancy, not only within the GI tract, but also in non-gastrointestinal organs. Because of this elevated cancer risk, early and proactive surveillance is essential. Screening includes colonoscopy, beginning at age 18, to monitor for colorectal polyps and malignancy, upper endoscopy and small bowel series, which should be started as early as age 8 to assess for upper GI and small bowel polyps. Additionally, due to the risk of sex cord tumors and breast cancer, early mammograms are recommended, and testicular examinations should begin in boys under age 12. This aggressive surveillance strategy is key in reducing morbidity and mortality through early detection and management of potential malignancies. Colon cancer screening is essential for early detection and prevention. In average-risk individuals, screening should begin at age 45. The preferred method is a colonoscopy every 10 years. However, alternative options include fecal occult blood testing, FOBT, or fecal immunochemical testing, FIT, annually, FIT with DNA testing every 3 years, CT colonography, or flexible sigmoidoscopy every 5 years. There are special situations that require earlier or more frequent screening. For example, patients with a first-degree relative who has had colon cancer or a high-risk adenomatous polyp should begin colonoscopy at age 40, or 10 years before the relative's age at diagnosis, whichever comes first. If the relative was diagnosed before age 60, colonoscopy should be repeated every 5 years. If the relative was diagnosed after age 60, the patient may follow the routine 10-year screening interval. In patients with ulcerative colitis, who are at increased risk for colon cancer due to chronic inflammation, screening should begin 8 to 10 years after diagnosis, and then repeated every 1 to 3 years depending on individual risk factors and findings. When performing colonoscopy for colorectal cancer screening, it's important to tailor the follow-up timing based on the quality of the exam and the findings. If a polyp is removed in a piecemeal fashion, regardless of its size, the colonoscopy should be repeated in 6 months to ensure complete removal of all residual tissue. In cases of poor bowel preparation or incomplete visualization of the colon, the exam should be repeated within 1 year to obtain adequate assessment. If the colonoscopy is incomplete, for instance, due to anatomic or technical reasons, it should be repeated as soon as possible. If a large polyp greater than 10 millimeters is found, whether it's sessile serrated, adenomatous, or even hyperplastic, a follow-up colonoscopy is recommended in 3 years due to the elevated risk of progression to malignancy. Small colorectal polyps are defined as less than 10 millimeter. Malignancy risk from least to most concerning. Hyperplastic polyps are the most benign, followed by adenomatous polyps, with sessile serrated polyps carrying the highest malignant potential among small polyps. In hyperplastic polyps, if a patient has more than 5 hyperplastic polyps, this raises suspicion for a serrated polyposis syndrome, and colonoscopy should be repeated in 3 years. If the patient has fewer than 5 small hyperplastic polyps, a standard 10-year follow-up is acceptable. In adenomatous polyps, tubular adenomas, 1 to 2 small adenomas, then repeat colonoscopy in 7 to 10 years. 3 to 4 small adenomas, then shorten the interval to 3 to 5 years. If there are 5 or more, repeat in 3 years. In serrated polyps, 1 to 2 small sessile serrated polyps, then surveillance in 5 to 10 years. If the patient has 3 or more serrated polyps, colonoscopy should be repeated in 3 years. Anal fissure is typically in posterior location. If anal fissure is anterior or lateral, raise concern for inflammatory bowel disease, should undergo colonoscopy and small bowel imaging. Treatment involves topical nitroglycerin, which improves blood flow and helps in promoting anal fissure healing. Topical hydrocortisone for anal hemorrhoids, not for fissure. If both present together, need nitroglycerin first. Niacin deficiency presents with 4 Ds, including diarrhea, dermatitis, dementia, and death. In alcoholic with petechiae and normal platelet, suspect vitamin C deficiency. Thank you for watching. Hope it helped.